Okay, our next presenter is Kim Gibson, and Kim is a local girl here from South Australia at the University of South Australia and a neonatal critical care nurse. She's been actively researching and in particular looking at the development of a non-contact method to monitor heart and respiratory rates. So, very interested to hear this, Kim.
So good afternoon all. Today I'm presenting my minor thesis as part of a Master of Nursing degree titled, Non-Contact Heart and Respiratory Rate Monitoring of Preterm Infants based on a Computer Vision System, a Method Comparison Study. So I'd firstly like to acknowledge the support of my supervisors and the consultants on this project, particularly my colleagues in the School of Engineering. So this presentation will outline the aim of my research, provide some background as to why this technology is so essential, explain how we actually extract physiological data through a non-contact method. I'll outline my interim results and close with some discussion. So the aim of my research was to determine the accuracy of a proposed non-contact system to detect the heart and respiratory rate relative to the heart and respiratory rate obtained by 3-lead ECG in preterm infants in the neonatal unit. And my specific objectives were to determine if this system is accurate for measuring neonatal heart and respiratory rate when compared with a control, which was the ECG. I also wanted to identify factors that may influence data extraction, particularly the accuracy, when filming neonates, and provide recommendations for how we can improve our method if required. And lastly, to provide insight for how we can get this non-contact system into a functioning prototype. So as you are aware, ECG is the gold standard for continuous cardiorespiratory monitoring for our patients. It does, however, require the use of adhesive electrodes. So preterm infants have a very weak epidermis, and when we actually apply an adhesive layer to the epidermis, when we remove that adhesive layer, it can take up to about 80% of the epidermis with it. And this therefore results in trauma, as you can see up on screen there, pain, susceptibility to infection, heat and water imbalance and electrolytes. Our previous published study investigated the use of this non-contact system with a group of healthy children from the ages of 1 to 5 years, and we were able to accurately detect their respiratory rate using a respiratory monitor as a control. So a neonatal study was therefore warranted to test the rigour of this system on infants who we know have higher heart and respiratory rates, can periodic breathe quite subtly, and of course have episodes of apnea and bradycardia. So you're probably wondering, well, how do we actually extract heart and respiratory rates using a non-contact method? So we detect respiratory rate from simply filming the chest and identifying chest rise and fall. To detect heart rate, we can study the head. When our carotid arteries are pumping blood to our head with each heartbeat, our head actually oscillates by about 5 millimetres in amplitude, which is, of course, is undetectable to the naked eye. But in both scenarios, we apply a certain amount of magnification to the area of interest, so either the chest or the head, to detect this data. And then we apply more signal processing techniques to essentially clean up the image, because when we apply so much magnification, we can actually distort the image. So it's similar when you take a photo at night and you get that real grainy appearance. So there's some algorithms to enhance the image. So I've got an example here on the left is a child who's obviously breathing quite normally and being dressed, and especially with a blanket on, parents can often be tempted to go in there and poke their child to see whether they're still breathing. And if you can play the one on the right there. So just swivel over the right. Can you pause my time? Not working? No. Okay. So what happens is the chest rises quite substantially. We've magnified it 20 times. There we go.
Look at that.
And you can see that the region of interest is her chest, so of course her head and her legs and her arms are in proportion there. Okay, so my study was conducted in the neonatal intensive care unit at the Flinders Medical Centre here in Adelaide earlier in the year. 10 preterm infants were recruited who had a combination of factors, such as receiving phototherapy. I had 2 infants recruited who were on CPAP, and most of them were in incubators and a few were in bassinets. And essentially we wanted to recruit babies with these potential confounding factors to see whether they influenced data extraction. So infants and their ECG were filmed for 10 minutes concurrently, and you can see my experimental setup there. 3 data points were selected at 3, 6 and 9 minutes in the 10 minutes of filming. For statistical analysis, comprised of firstly conducting Deming regression, which essentially looks at the relationship between the both methods to see whether there is a relationship or a trend. So for example, our non-contact system may have consistently produced a heart rate of about 10 above the ECG, for example. Then Bland-Altman analysis was undertaken, which evaluates the average in the difference between the both methods, or the bias, and determines the limits of agreement, so essentially the range in the differences. And of course, I had ethics approval to do so. So in terms of results, so phase 1, I'm excited that our method was able to actually capture and detect apnea when the ECG did not in one of the cases. So during this apneic event of a baby on CPAP, as you can see, the ECG determined the respiratory rate to stay in the 20s during this 10 seconds, which is assumed to be artefact because the baby definitely wasn't breathing. In this scenario, the ECG alarmed bradycardia only. And this infant, as you can see, had quite a substantial apnea for a good 8 seconds with associated bradycardia and desaturation, which is the definition of a true apnea. And I'll be going back and analysing other episodes to see whether this was an isolated event. Okay, so when analysing the 30 data points for all 10 babies, which was phase 2 of my statistical analysis, firstly, I could not see a relationship existing between both methods when using Deming regression. The respiratory rate derived from the non-contact system, on average, we were about 2 breaths out from the ECG. And with heart rate, we were on average about 8 beats per minute, so that was the bias, and this is really encouraging. However, there were times when our non-contact method was significantly out compared to the ECG, so we could have been 20 beats above or 5 below the ECG, and with respiratory rate, we were sometimes 25 above or 10 below. And we think there are some factors coming into play with that. So in terms of where to from here, we know that there is some variation in lighting, and particularly babies who move regularly, we think actually contribute to some of the inaccuracies in some of the cases. And I'm currently in the process of, in collaboration with the engineering team, analysing exactly how these variables came into play. In moving forward, we need to actually work on our algorithm to accommodate for these variables, which are, of course, very common to the neonatal population. The results of this study will contribute to the development of a more rigorous method, and future research is currently being planned to investigate this use of this method where we can't actually apply electrodes such as in the Burns patient during retrieval and transportation, and my interest in newborn resuscitation, because at the moment we rely on clinical assessment to determine heart rate and apply oximetry at 1 minute, which we know has major limitations. So this technology does have the potential to hopefully transform how we monitor our patients in varying contexts, so I think it's wise to watch this space. Thank you very much.
Great, thank you very much. Does anybody have a question for Kim?
Johnny?
Yes.
Your bias wasn't very big in both of those, but the limits of agreement were
Yes.
lower. Was there a sense that you were reaching the limits of the method? Was it happening at the highest heart rates or the lowest heart rates? Was there a pattern to that?
I haven't looked at that yet, to be honest, and I'm also going to go back and see exactly who those outliers were. So I had a baby under phototherapy. We had a baby that was really active. We actually filmed when a mum was cuddling the baby too. So although my results are fairly interim, I will be going back and looking more in depth and working with the engineering team. Although the mean bias is encouraging, we do need to allow for those major variations. So that's where there needs to be work done. Particularly also too, I filmed during quiet time in the NICU. So we turned the lights off, and I think that had a major influence too. There's also another method that we can use to obtain heart rate through imaging photoplethysmography. So looking at the peripheral pulse, and of course we couldn't do that because of the poor lit area. So that's a limitation of our research. And our research does mirror work that's also being conducted using similar methods, non-contact methods in the neonatal population. It's reduced lighting and the regular movements of neonates that are confounding factors. And a lot of researchers are having this problem. So I have to speak to the engineers about what actually, in terms of what we can do to our algorithms. My engineer that I'm working with said, Kim, can't you make the infant stay still? I said, unfortunately not.
Oh dear, okay. Are there any other questions?
I have a question. What kind of cameras are these? And is the principle in the main brain or processing power is in the camera, or it's on the software?
So essentially I just set up 2 Nikon cameras on tripods, took the films away, and the engineers used a computer software system, and it's called MATLAB. I'm not sure if you've heard of it before. So it's still in MATLAB, so we actually haven't gotten it out of the computer environment yet and gone to a functioning prototype. The engineers assure me that this technology is going to be set up so that it can be done on an iPhone. So initially, they could see that this kind of technology would be great for monitoring infants at home, so replacing the commercial apnea mats that have got major problems. So essentially just having a little $5 camera in the baby's room with the parents having the iPhone in their room, and they can see the heart rate and respiratory rate of the child.
And I just wondered, are there any other questions? Can I just ask him, have you done this in actually babies who are moving, or it's just all been in stationary babies?
So in an incubator, but the babies have been moving in the incubator.
Oh yeah, but you haven't been moving the incubator to a different place.
No. So as I mentioned before, I think there's definitely clinical implication here for doing retrievals by road and fixed wing. Being an ex-retrieval nurse myself, I can understand the implications here. MRI, not having to take an MRI monitor in there. Burns patients. So yeah, I think this is obviously a pilot study, so we really want to make sure that we can nut out these variables before we take it elsewhere, and I think the neonatal population is worst for those variables. So if we get the methodology right here, we can then think about other clinical applications.
Great. Thank you.
Thank you, everyone.
Thank you, Kim.